Welcome everyone to our Internal Emergency Medicine Split Share Visits Lecture Part 2. This presentation is brought to you by your coding teacher, Mai, yours truly. So before we proceed, please do visit our website at www.mclchargeCaptureandCoding.com. You can purchase study notes and you can schedule an online one-on-one tutorial from that website. Again, our topic for today is internal emergency medicine, focused on split or share visits, part 2. If you have not yet watched the lecture video on split or share visit part 1, here is a link. I do hope you enjoy the video. And our food for thought for today is from Mortimer Adler. He was an American philosopher, educator, editor, and advocate of adult and general education. He wrote, "The purpose of learning is growth, and our minds, unlike our bodies, can continue growing as we continue to live." So I would say this: learn, relearn, and learn some more. It really doesn't hurt to learn more and more every day. So our previous video taught us everything we need to learn about split share visits, from the definition to the guidelines to what to look out for in the attending's TPA, and knowing who to bill based on MDM. Today we will apply what we learned through some sample exercises focused on the attending's TPA. Example number 1. As you can see, this is an attestation by physician X, who is a doctor of osteopathic medicine in an emergency department setting. The TPA reads, "I have discussed the patient's care with the NP and I agree with the plan. The APP has communicated his evaluation verbally, and it was made clear his evaluation was inconsistent with port compression, spinal epidural abscess, cauda equina, because the patient has 5 out of 5 strengths in bilateral upper extremities and lower extremities. No urinary incontinence, retention, weak stream endorsed. No saddle anesthesia endorsed. No recent spinal procedures or surgeries. And the patient was afebrile, no IVDA." So based on this TPA, the physician did not see the patient. Also, the mid-level provider will get the billing credit because it appears the attending did not perform a substantive portion of the MDM. We confirm this by knowing that in this TPA, the MDM level of service details of the attending physician are missing. And also, some physicians or attendings will use the smart phrase, "Additionally, my history, physical exam, and or MDM are as follows." They include their own MDM in the TPA. So we don't see that here, and it's missing in the TPA. So let us modify the scenario. What if the physician stated that he saw and examined the patient? Does that mean he can bill for this visit now? Well, the answer is still a no. There's no substantive portion stated in this TPA, meaning that it is still missing the medical decision-making documentation of the attendee. So we must give the billing credit to the NP in this case. In our example number 2, the TPA reads, "I discussed the case of patient D with the PA and agree with the diagnosis of fall, initial encounter, chronic left-sided low back pain with left-sided sciatica. And also there is a consult statement. I spoke with the social worker and they agreed to find a spot for the patient at the hospice in Northwest." Example, the MD has not seen nor examined the patient either, so no direct contact from the MD. So we can assume that the PA did see the patient. But notice the inconsistency of this attestation. Based on the standard TPA template we studied from our previous tutorial video, the physician did agree with the PA's listed diagnosis, but he stated that he only discussed the patient's case with a mid-level provider and no shared testament about his own MDM. This TPA, if you would agree with me, is a bit confusing because the physician did not include the smart phrase, "Additionally, my history, physical exam, and or MDM are as follows. So check with your current department's policy if this is okay, and if you can still consider this as an acceptable substantive portion, because some organizations do not accept this. And if that is the case, since he only discussed with the PA, I would query the provider for the correct attestation template for accurate billing and coding, and also to make sure that the consult statement is his and for that particular encounter and not just added in error, because some providers would do copy and paste in the template. So, well, that wraps our lecture for today. I hope you have a better understanding of our attending's TPA in a split or share encounter in the emergency department setting. You can visit the CMS website for more information about this topic. And if you do have questions, please contact me through this email, and I will be more than happy to respond. Again, thank you for watching, and please do click like on the videos and subscribe on our YouTube channel. And thank you for viewing. Have a great day. Happy coding.